Welcome to another case presentation for the psoriasis disease care. This is Dr. Elaine Husney. I'm a rheumatologist at the Cleveland Clinic, and it is my distinct pleasure to introduce Dr. Abrar Qureshi, who's Assistant Professor of Dermatology at the Harvard Medical School, and he is also the Vice Chair of the Department of Dermatology at Brigham and Women's Hospital. He's also well-trained at the Harvard School of Public Health, which occurred immediately after his clinical dermatology training. I first met Dr. Qureshi, who's both a friend and a colleague, during my residency training in Boston at Beth Israel Deaconess Hospital, where we quickly shared an interest in derm room-related disorders. And later, when we both became staff at Brigham and Women's Hospital, we co-founded the Center for Skin and Related Musculoskeletal Diseases in 2003. So Dr. Qureshi certainly has a unique perspective in caring for patients with severe psoriasis and psoriatic arthritis, in that he has a multidisciplinary clinic in this area. He also has research interests in epidemiology and outcomes research in the area of skin cancer, and is funded by the National Institutes of Health. Today, he's going to provide a comprehensive review of psoriasis, including the diagnosis, epidemiology, the pathobiology, as well as treatment, and end with a spectrum of cases, including recalcitrant cases.
Hi, this is Abrar Qureshi. I'm a dermatologist at the Brigham and Women's Hospital, and I've been fortunate to be working in the last few years with rheumatology closely in a combined dermatology-rheumatology clinic. Today I'll be talking to you about psoriasis and really managing patients with the skin disease. We'll start off with the basics, and then we'll go into some more refractory cases as we go through the next few minutes. So the next slide really illustrates for you how psoriasis has been characterized more beyond just an inflammatory skin disease, but actually an inflammatory systemic disease. It is characterized by scaly plaques that affect between 2 to 3% of our population in the United States. And although the initial hypotheses about 3 to 4 decades ago were that psoriasis was an aberrant growth of keratinocytes in the skin, since then, a lot of work has been done to prove that psoriasis is really indeed an inflammatory condition, mainly T-cell mediated as well as neutrophil mediated, with elevated inflammatory cytokines both in the blood and lesion of skin. In terms of epidemiology on the next slide, there are about 10 to 20% of patients with psoriasis who have moderate to severe disease, but not everyone gets to see a dermatologist routinely, and certainly a large proportion of them, maybe up to one-third of them, may have morning stiffness with signs and symptoms of inflammatory psoriatic arthritis. Certainly the cost of care for psoriasis exceeds $800 million a year based on a burden of skin disease report that was published by the American Academy of Dermatology in collaboration with the Society of Investigative Dermatology about 5 years ago. So it's a significant disorder in dermatology, and certainly a lot of discussion happens on a daily basis in clinics, in hospitals throughout the country in terms of management of the cutaneous disease, as well as modifying potential systemic comorbidities that may be associated with psoriasis. The question of whether it's an autoimmune or genetic disease comes up a lot. Suffice it to say that psoriasis is probably one of the highest monozygotic twin concordance rates compared to any other inflammatory condition, including rheumatoid arthritis, type 1 diabetes, and Crohn's. It also has been associated with triggers in terms of infection, such as streptococcal infection and inflammation, such as in the teeth or periodontal disease as well. This image shows you some classic plaques of psoriasis. Probably the most important criteria in terms of management of psoriasis have been or currently are the extent of body surface area covered by plaques. The plaques have 3 components. They are scaling or scaly. They tend to have a raised component, so they're thick and raised above the skin surface. And then they have a red background. And when patients tend to scratch these plaques, the plaques tend to bleed easily. So body surface area is a very important consideration in the management of psoriasis in terms of choice of therapy. The other big criterion for management of psoriasis is really quality of life. great deal of work has been done to characterize or quantify quality of life issues in psoriasis. Patients can have a small body surface area covered, such as genitalia or pons and soles or their face, and those areas can have, involvement of those areas can have a huge quality of life impact on these patients. When we manage psoriasis, most of the time, when the body surface area is less than between, let's say, 10% or 15%, patients may be considered reasonably well managed on topical therapy. But above that threshold, or if quality of life is an impact, we tend to manage these patients with systemic therapy. And that really is more of the goal of today's talk. But I will go into some basics in terms of management. On biopsy, this is a histologic sort of photomicrograph of what psoriasis skin looks like. In the cartoon below, you see that normal skin on the left side is not thickened. The vasculature is within normal limits. You see these hairpin loops of capillaries going up and down from the deep dermis to the superficial dermis, and then back down. In psoriatic skin, the cartoon on the right side, you see the skin is much thicker. There's a lot more inflammatory cells in the epidermis. The vasculature is much more engorged, and really a lot more going on in terms of inflammatory cells in the dermis as well. And so in the photomicrograph, you see that the stratum corneum here is almost completely parakeratotic, which means that there are nuclei seen within the shedding keratinocytes, which typically should not be there. You see there's loss of what's called the granular layer in the epidermis, and so the skin is quite thickened. And then you see this irregular or regular psoriasiform hyperplasia with very prominent blood vessels and a lot of inflammatory cells. These darker cells in the white area of the dermis signify a lot of inflammation going on. So psoriatic skin is very inflamed, and the more body surface area that's covered, the higher the burden of inflammation in these patients. This is a close-up of the epidermis, the surface, and you see that they're both T cells, or mononuclear cells, and then there are also sort of multinucleated cells, or neutrophils, in the superficial scale crust. So a lot of inflammatory changes occurring in the cell, with some microabscesses occurring in this inflammatory condition. This is a nice illustration from 2005, Annals of Rheumatic Disease, which shows that the number of cells in normal skin is much fewer than the number of cells in the repertoire of cells in inflammatory skin, both from dendritic cells all the way down to T cells. And certainly there are more neutrophils. There are neutrophils in psoriatic plaques when there are no neutrophils in normal skin. So that's an interesting aspect of psoriasis as well. This cartoon illustrates for you the Th1 pathway of cytokines, just to again signify how much inflammatory change is occurring in the skin. On the top left, you see that the problem really begins with, we think, dendritic cells or Langerhans cells that present antigen to T cells, and through a cascade of both interleukin 12 and 23, which has become an important cytokine target for psoriasis therapy. You can get maturation of Th1 cells, and more cytokines are generated, and there's almost this vicious loop of TNF therapy, or anti-TNF, or TNF cytokine generation, where the inflammation just propagates itself. Interferon is a very important part of psoriasis pathophysiology as well, and in fact, psoriasis is very much considered an interferon in some ways. And certainly, the inflammatory cascade, as demonstrated on this cartoon, also shows the intense inflammatory change around blood vessels with leukocyte migration, angiogenesis going on as well, and a clonal expansion of T cells. So again, signifying that there's a lot of inflammation going on in the skin, which may potentially impact a number of comorbidities that we're seeing in relationship with psoriasis, including both diabetes, cardiovascular disease, as well as hypertension, etc. In terms of classifying the skin disease, it can be classified into plaque-type psoriasis, gut-type psoriasis, and I'll show you pictures of all these. Inverse psoriasis, which is really considered the hidden type of psoriasis, palmar-plantar disease, pustular disease, as well as the nail changes. And a lot of patients come to us with the question of how to manage the nail changes. The classic anatomic locations for psoriasis, almost always, it really, in terms of plaque-type disease, about 80% of the time, it really involves the scalp, elbows, and knees, and legs. About between 10 to 50% of patients can have nail disease, and nail disease varies as well. And then palmar-plantar psoriasis is about 10 to 12% of patients who have psoriasis. Some have proposed that the palmar-plantar disease might be a very different type of psoriasis. In terms of exacerbating factors for psoriasis, what makes psoriasis happen and more severe, and it's worth knowing these when you're managing your patient with skin disease, especially someone who may be refractory to therapy. So certainly direct skin trauma, the Kebner phenomenon, is a consideration, very important consideration in the management of these patients. When patients are started and stopped on systemic steroids, such as, let's say, a patient who's receiving systemic steroids for asthma is started and stopped on systemic corticosteroids, that can be a factor that leads to psoriasis worsening. Extremes of temperature, cold weather in particular, or lack of sunlight. Streptococcal pharyngitis we talked about. Emotional stress is considered to be a very important risk factor for psoriasis. And more recently, some of the work that our lab has done and others have done, both in the U.S. and internationally, has shown that alcohol intake, smoking, increased weight gain are all associated with psoriasis, either development or worsening. Most recently, we published a paper looking at the association between periodontal disease and psoriasis, and severe periodontal disease with bone regression in the jaw can also be associated with psoriasis onset. HIV disease has been associated with psoriasis worsening, as has use of certain medications, including beta blockers and certain antihypertensives, as well as lithium. Lithium is a well-known exacerbator of psoriasis, and quite a challenge to manage patients who have bipolar disorder who are on lithium and their skin disease flares. Now, this is a list of the medications that exacerbate psoriasis. So as I mentioned, beta blockers, lithium, certainly interferon alpha. We see this happen in patients who receive interferon either for viral conditions or for cancer, in particular patients with hepatitis C infection who receive interferon alpha therapy flare quite a bit. Antimalarials and ACE inhibitors have been reported to flare psoriasis. And as I mentioned earlier, withdrawal of prednisone and cyclosporin can cause psoriasis worsening. So let's run through topical therapy really quickly before we jump into more systemic therapeutic considerations. So how does one write a prescription for topical steroids? Most patients with psoriasis are very good at using topical steroids. This becomes really part of their therapeutic regimen for most patients, even if they are on systemic therapy. So when you're writing a prescription for topical agent, these are the important indicators on this slide. You want to write for the name of the topical agent, of course. The vehicle is important because you can prescribe the same topical agent in a ointment, cream, or lotion. Directions and frequency are important. Typically, we ask patients to apply topicals once a day. Twice a day is a big deal, and unless the patient's retired or not working, it's really hard to keep an ointment on board because they can be greasy and quite messy. Size of the prescription, typically you can get away with writing for a large container, large tube, large bottle, but if you are working on an electronic medical record and there is an ability to know the size of the agent being prescribed, the container being prescribed, that can facilitate writing a prescription. In terms of number of refills, if I'm writing for a potent topical steroid, I'm very careful about not giving the patient too many refills and seeing them back in close follow-up to make sure I don't really miss out on any topical steroid side effects. The side effects include atrophy of the skin, redness of the skin, hyper or hypopigmentation, especially in patients who have darker skin color. And the topical steroids must never be applied around the eyes because of the risk of ocular side effects that include early cataract development as well as glaucoma. Topical steroids can really increase intraocular pressure quickly, and so that is a concern for these agents. This is a ranking of topical steroids on this slide, and there you go from class 1 all the way to class 7. Class 1, worth remembering a class 1 and maybe a class 4 or 5 topical steroids, so clobetasol ointment. You do not need to remember the percentage for this when you're writing for it. It comes in ointment, cream, and lotion, or solution. So solution you'd use more on the scalp. We'll talk about that in a second. And then the other one to remember is triamcinolone, either ointment, cream, or lotion. In terms of vehicles, Remember, the ointment has the highest penetration through the epidermis, but really is much more messy than cream and can be applied really to only very dry, scaly areas, versus a cream, which is much easier to use, absorbs quicker, just does not have the same efficacy, but is worth considering in patients who don't have very severe disease. Lotion and gels and solutions is what we use typically on the scalp, because you're trying to treat the scalp and not the hair itself. Cream and ointment gets absorbed in the hair, so hence the importance of using solutions to deliver the drug. So here's an example of a number of topical therapies for psoriasis. Topical steroids, certainly mid to high potency for most areas, and much lower potency for intertriginous or inverse areas in the face. Calcipotriene is a reasonable steroid-sparing agent. It's a vitamin D analog that can be used once the topical steroid has done its job to essentially keep the psoriasis at bay. Certainly, patients will notice that psoriasis comes back over time with the use of calcipotriene, but it is a wonderful steroid-sparing agent. Tazarotene is a retinoid, is pregnancy category X, should not be used in women of childbearing age without counseling. It works best in combination with topical steroids. Protopic or tacrolimus is a non-steroid calcineurin inhibitor that's used for the face and intertriginous areas, worth considering in patients who have facial involvement. And again, all of these are available in all vehicles. Example of topical therapy, you could combine topical steroids plus calcipotriene. A nice combination is halobetasol with calcipotriene or betamethasone with calcipotriene. Patients can mix these two, apply them, let's say once a day for about 6 weeks. Once the plaques settle down, they can stop the steroid and continue the calcipotriene indefinitely until the plaques come back. It's worth seeing the patient back in 6 weeks to see how they're doing. In terms of systemic therapies, the older systemic therapies, we'll talk about first, and then we'll talk about the biologics. And I'll show you some pictures of some cases and how you'd manage them, give you examples of that. So phototherapy is probably the old tested skin-directed therapy for psoriasis, and it's still used very, very commonly. Ultraviolet B, both narrowband and broadband UVB are commonly used. Again, patients who have a large body surface area, more than 15% or 20%, do very well with phototherapy. The biggest drawback to phototherapy is convenience. Can patients come into your clinic 3 times a week for therapy? That really is a big limiting factor. Methotrexate, both given orally and sub-Q, is a reasonable choice in our patients with moderate to severe psoriasis. And we almost always jump to methotrexate first and then use it in combination with other biologic agents. Acitretin or soriatane is also a drug we use frequently. This is a non-immunosuppressive drug and actually works quite well in the right patient. This cannot be used in women of childbearing age at all, so we reserve it either for postmenopausal women or in men. Has some, it does have hepatic side effects, but in general is well tolerated. It is not immunosuppressive in patients who might have infection or patients who may have, there might be a workup going on for malignancy. Acitretin is a reasonable choice. And finally, cyclosporin is considered to be a go-to drug for sudden phase of psoriasis, especially pustular psoriasis. It has a rapid onset of action. In the short term, can cause, obviously, increase in blood pressure, but in general, works quite well in the short term. Long term, of course, there are concerns about renal side effects, but the drug is really used as a go-to drug for temporary bridging of therapy during flares. Moving on to the anti-TNF biologics, there's adalimumab, etanercept, infliximab are the 3 common ones we use. The newer ones that have not been approved for psoriasis are certolizumab and golimumab. Golimumab is approved for use in psoriatic arthritis, so we do have access to it for our patients with psoriatic arthritis. We do certainly use certolizumab and golimumab off-label therapy for our psoriasis patients when other options run out. These are reasonably well tolerated. Certainly, they're immunosuppressive medications. We tend to use them in patients with moderate severe psoriasis. A couple of tidbits on sort of how I use these medications. So I usually use etanercept or adalimumab as sort of the go-to medications in patients who are getting the medication sub-Q at home. Patients where compliance might be an issue, or if they weigh more than, let's say, 150 kilograms, we may consider weight-based dosing with infliximab if adalimumab does not work or does not have efficacy. However, the side effect, the problem with infliximab is that patients have to come in for infusion. Certolizumab and Cimzia are really medications that I personally use once the other 3 anti-TNFs have failed. And we've had some good success with both these medications in our patients with psoriasis and psoriatic arthritis. Probably the biggest take-home point is in your patients with quote-unquote refractory disease, I would highly recommend giving these medications a chance for about 4 to 6 months. Either use them at the dose recommended, a higher dose, or in combination with methotrexate or acitretin or a retinoid before a patient is considered failing a therapy. And we have a lot of conversations with our patients at their visits to discuss whether they really are failing a therapy or not before switching therapy, because it is not always a home run to switch therapy. The other biologic agents worth mentioning, Ustekinumab, Stelara, is a human IgG. It is an anti-P40 molecule that blocks interleukin-12 and interleukin-23. It is now approved for use in psoriasis, and we'll be using it for the last almost 2 years. It is dosed quite infrequently in patients who receive their first dose. They get their second dose at 4 weeks, and then it's every 12 weeks thereafter. The slight difference in dosing is it is weight-based dosing in that patients who are 100 kilograms or more receive 90 milligrams or 2 shots of the of Ustekinumab at each time point. Patients who weigh less than 100 kilograms get 45 milligrams or 1 shot. There's been some good success. There's very little safety data on the medication because it's new on the market. There seems to be no black box warning, but again, just like the anti-TNFs, we do screen our patients for tuberculosis at the outset. Ustekinumab is also an anti-P40 molecule, which is now no longer under development, has been taken off the development track. Abatacept Orencia is a fusion protein anti-CTLA4 Ig, and it's a medication that some of our rheumatology colleagues do use it in patients who are refractory to therapy for psoriatic arthritis. It has almost no efficacy for psoriasis, and patients who are on it for psoriatic arthritis, the psoriasis tends to flare. Rituximab, again, similar story with abatacept, may be used in psoriatic arthritis by some rheumatologists who may not be successfully treated with anti-TNF therapy, however, has very little efficacy for the skin disease. Tocilizumab Actemra, again, did not do very well in psoriasis clinical trials, but is being used for rheumatoid arthritis and may be used for psoriatic arthritis by your rheumatology colleagues. Worth knowing that, again, patients may not respond to tocilizumab. Apremilast is on the market and may be considered for psoriasis. It's a phosphodiesterase 4 inhibitor. And then finally, in terms of biologic agents that are coming down the pike, brodalumab is an anti-IL-17 receptor antibody. Cytokines is an anti-IL-17A antibody, and Ixekizumab is an anti-IL-17 antibody as well. So there are 3 anti-IL-17 molecules coming in. Cytokines has completed clinical trials already. Brodalumab is in phase 3, and Excimer is also in development. So some exciting new molecules coming down the pike for psoriasis therapy. And the big concern with these medications really is infection, because you are targeting IL-17, but the initial data from clinical trials has been quite promising. In terms of comparative primary endpoint data for the currently approved TNF inhibitors, if you look at both PASI 75 responses as well as ACR20 for the 4 anti-TNF agents, 4 of the 5 that we talked about earlier, you can see that across the board, infliximab seems to be the most efficacious at about 80% PASI 75 versus adalimumab, which is 71%, and the etanercept is about 49%. And, if you look at ACR20s, they're quite similar across the board. So really, in terms of skin efficacy, there are some differences, but in terms of ACR20 responses, the responses are quite similar across the board. In terms of management of our patients, we're managing patients with psoriasis. We almost always first screen them for psoriatic arthritis. And this is just an algorithm to remind me to tell you that when you're managing the patients with psoriasis, it really is important. It behooves us to make sure that we screen them or talk to them about morning stiffness and the potential of psoriatic arthritis. And if they do have psoriatic arthritis, either manage them ourselves or in concert with our rheumatology colleagues. So in this case, when patients have mild psoriatic arthritis, they get managed a certain way. If they're moderate to severe psoriatic arthritis, there's an algorithm outlined in the slide. But the most important point I want to drive home is please consider the diagnosis of psoriatic arthritis in all your patients with psoriasis. So to give you some case examples, here's an example of a patient who has localized disease, really elbows and knees. You can see the knees in this image. Patient like this with localized disease certainly can be offered topical therapy. I might offer them a combination of halobetasol plus calcipotriene applied once a day, see them back in about 6 weeks, see how they're doing. If they begin to respond, then I can either switch the combination to weekends, keep calcipotriene going on the weekdays, limit use of the topical steroid, and see how they do. If the body surface area goes up, we can certainly go to phototherapy as the next level, and then usually I'll follow a therapeutic ladder to methotrexate, and then anti-TNF therapy and or Ustekinumab. So that would be the algorithm here. For scalp disease, we have seen patients with just localized scalp disease. I tend to, again, favor topical therapy, which in patients like this with thick scale underneath the hair, it's very difficult to deliver topical therapy. There are a number of light brushes, light delivery devices through brushes that have light coming through the bristles of the brush that can be used to deliver light to the to the scalp. And these have been somewhat efficacious, but when all of these fail, we do tend to use a combination of methotrexate and or anti-TNF therapy for our patients who respond quite well. When there's nail involvement along with skin involvement, again, topical therapy does not work for nails. Light therapy does not work for nails. They really need to be on a systemic agent. There's data on almost all the biologic agents, including the TNF agents as well as Ustekinumab for nail efficacy. Again, because these medications are immunosuppressive, we're cautious about how we use them. Patients really have to, if they have only nail changes, we'll consider methotrexate and or the anti-TNF agents for their Stelara or Ustekinumab for their therapy. But for nail changes only, we have explicit conversations with patients about safety and efficacy before we embark on systemic therapy. But this is a slide just to remind me again to tell you that nail therapy does require systemic therapy. This is a young man who presented with some pain and stiffness in his hands and sudden onset nail changes over the last 2 to 3 months. You can see where the nail changes began. He still has normal nail distally in that third digit and fourth digit, and then proximally the nail is suddenly becoming extremely pitted and atrophic and dystrophic. And so at the time of exam with our rheumatology colleagues, he did not have active synovitis. There was no element or evidence of bony changes on plain film. And so at the time he was offered methotrexate, he did try it for about 4 months and his nails cleared. But then he decided that it was not in line with his social life because he did like to have a glass of wine and a beer with dinner either every night or associated with his friends. And so he was switched to an anti-TNF agent, etanercept, and he did quite well in terms of his nails. Period. He has come back to clinic asking if his nails are normal, should he discontinue etanercept, and we have considered that. But at this time, he elected to stay on the medication. This is a patient with much more severe psoriasis, almost erythrodermic. So just give you an example of how we approach a patient like this. You can see quite thick scale. When I use the word erythrodermic, I really imply that he has almost 80 to 90% body surface area covered with almost no skin. You can see that's visible, that's normal, maybe a few islands of sparing or areas clear on the abdomen. Thick scale. And the next slide, you can here see his feet and hands are involved as well. And he basically is quite miserable, very itchy. Some of the skin hurts with burning pain. So in someone like him, he had a number of issues going on. He had quite severe disease. He also has issues with his liver in terms of alcohol intake in the past. So we did not want to start him on on methotrexate. He has high blood pressure, cannot get cyclosporins. We can't bridge him with therapy. And although acetretin was considered, he has too much disease to be on monotherapy with acetretin. He cannot get phototherapy because he works in a day job and cannot leave work. It would be too much for him to leave work and come for an hour every 3 times a week or every other day. So we were weighing therapies, and he had failed a number of therapies in the past, including phototherapy. So we elected to put him on adalimumab, Humira, 40 milligrams every other week, and he really has done quite well. He's completely cleared with therapy. So these are some of the treatment considerations in managing some of our patients with really severe skin disease. This is seborrheic dermatitis. Just to remind you that some of your patients with psoriasis will develop a facial rash. You really want to avoid applying topical steroids to this rash, because this rash will then require use of long-term topical steroids, and then you'll start getting into trouble with atrophy. We tend to treat this kind of an eruption with ketoconazole, 2% cream, applied twice a day to the affected area, and these patients tend to do quite well. You could also consider applying calcipotriene cream ointment to the area, and they seem to do well. If they have seborrheic dermatitis in combination with severe psoriasis or moderate to severe psoriasis, and they are on systemic therapy for their psoriasis, the seborrheic dermatitis will clear as well. Couple more cases. So this one is a patient who has gut-tape psoriasis. These two images, the front and back. These are plaques that are typically about 80% of the time associated with streptococcal infection somewhere in the body. So it really is important to make sure you look at the patient's perianal area, groin area, nasopharynx, oropharynx, to make sure you're not missing anything. And then sometimes there's a recommendation to check ASO titers. We tend not to do those because those could be titers from before. So what we tend to do typically with these patients is make sure we look in the throat, in the perianal area, groin area, make sure they don't have a fever or any other infection. If there is evidence of infection on culture, we will treat them with the appropriate antibiotic. If there's not, we typically tend to put them on narrowband UVB for about 6 to 8 weeks, and they clear quite well. Again, worth mentioning this variant of psoriasis. And finally, this is a case of a patient who was presumed to have psoriasis, actually does not have psoriasis. She actually has basal cell carcinoma. This is a lesion that was diagnosed as unilateral right knee psoriasis. And she was treated with topical steroids for the last 8 to 10 years. Wasn't getting better. Was sent to dermatology, and it turned out to be a massive basal cell carcinoma. So if you're doubting the diagnosis, it's not responding to topical steroids, you think you want to have the patient seen by dermatology, worth sending them in to be seen by your dermatology colleagues. So just in summary, what we've gone through is the basics of psoriasis in terms of it being not just a skin inflammatory disease, but a systemic inflammatory disease. I showed you evidence for the inflammation both in the skin and systemic circulation. We talked about types of psoriasis, both topical therapy and systemic therapy, the old systemic agents and the new biologic agents, and some tidbits on management of the variants of psoriasis, including gut-tape psoriasis, seborrheic dermatitis, nail disease, and inverse psoriasis. Thank you for your attention.
Thank you, Dr. Qureshi, for such an enlightening presentation. Not only did we cover the basics of psoriasis, but we also heard about the new advances in this area with very exciting new treatment paradigms. The wide variation in treatment approaches are fascinating, and the potpourri of cases are very helpful to better understand how to optimize treatment outcomes for patients with psoriatic diseases. I hope you've enjoyed this segment of psoriatic disease care, and we look forward to being on your internet once again. Thank you.